Thank you, Michael, and thank you all in our audience. And for those who can stay on, let's keep going.
Don't we all want to know what happens when we combine all of our optimal molecules and therapies
Indeed.
together?
Yes, have you done that experiment?
Not with these guys, no.
Joshua, what were you going to say?
I think the fascinating thing is that we should all recognize that we are all endorsing and validating this concept of the hallmarks of aging, right? All, if not most, if not all of our interventions do hit mitochondrial biology. There's the link to inflammaging. So these are very important take-homes, and I think the notion of combinatorial therapy or tailored therapies emerging as it has for all serious chronic diseases. There is not one magic bullet for any known human disease. It's always a combinatorial approach, and there are always individual susceptibilities. So I think that multiple approaches we've seen here today endorse that concept very nicely.
Well, and Josh, you also are developing an approach for a hypoplastic heart and heart failure. And
Yes.
that's the combination with surgery, just as another example.
Yes.
So all great
James,
stuff. Thomas, you wanted to say something?
just a logistical point. James, I see you posting stuff in the chat. You might want to choose a for everyone option. You're sending your information to the panel, but if you're wanting it to be spread more broadly to the panelists, choose the everyone option. Sorry, go ahead.
Oh, right. I don't know how I do that. Oh, host them to panelists. Oh,
Exactly.
everyone got it. Yeah, got it. Yes, I was responding to somebody's question. Yeah.
Yes. I'm wondering if I can ask Roger a question. Roger, can you tell me, and forgive my ignorance on this, what else does ALCAT1 do that we might? I mean, I understand the target and the purpose of the target, but what else does the enzyme do that we ought to think about when thinking about inhibiting it?
Yes, good question. So people often ask after my presentation, saying, "Well, it's such a bad gene. Why Mother Nature has not got rid of it?" We have to put this question in perspective. What is the function of this enzyme? The function of this enzyme is part of the cellular senescence response. So very early on, when we try to establish a stable cell line, overexpress its protein, most of the cells basically not survive. And those cells who can struggle to survive is because they already attenuate the inflammatory response. They are also attenuated the cellular senescence response. So that's the basic function. This enzyme promote inflammation. This enzyme promote cellular senescence. Both are quite important when we are young. Cellular senescence will be triggered by telomere shortening. So, and telomere shortening exposed double-strand DNA also induce inflammation by the cGAS-STING pathway. So when we are young, our body do everything prevent us develop cancer. So if there's telomere shortening, the cell will likely to become cancerous. So the cellular senescence is preventing cancer development. As we get older, those the senescent cell accumulate in our body. And we pay the price when we live longer because Mother Nature really does not select for longevity. It's actually human outlive most mammals because human has a brain. So the brain actually contribute to the race. Actually, you think about it, for women, menopause is basically a mark line that Mother Nature said you no longer need it. So senescence, menopause basically is a milestone for aging. For man, it's a different story. Man is the conqueror of the world. So man's productivity can continue. if you are the king, or if you are strong, just like a natural one. So to cut it short, this enzyme is involved in cellular senescence, probably cancer response when we are young. So it's not bad. Mother Nature does not select for longevity, so this enzyme has not shown its ugly side when we get old. So when we get old, when we pass our reproductive age, that's when this enzyme is showing the ugly part, which is promoting cellular senescence and mitochondrial dysfunction. By the way, this enzyme is sitting at the junction between ER and mitochondria. Most molecules, including nutraceutical, cannot penetrate mitochondria because mitochondria has double membrane. So that's where I don't understand some of the nutraceutical, how it works in antioxidant response. Because if antioxidant is highly effective in treating aging, then we should take a lot of antioxidant. But most of the antioxidant does not penetrate the double mitochondrial membrane. So fortunately, our enzyme is sitting outside the mitochondria. It's at the ER mitochondria junction. That's where remodeled phospholipid being transferred back to mitochondria. That's why this enzyme is fully druggable. And I answer more than you asked. I hope clear up some of the issues. Yeah.
That's a really elegant explanation.
Absolutely.
It
Looks like
does.
Chris has a comment about it. Yeah.
Well,
Yeah,
I just wanted to thank
respond.
you for organizing such an amazing conference today and this cross functionality here. I mean, we can really see how all the different products that each and every one of us here are working on to develop to bring to humans are very synergistic. Whether it's nutrition, whether it's light therapy, whether it's stem cells or even pharmaceutical intervention, acting at different stages of our life for our health span. I think you were covering here basically early prevention with nutrition and with hitting with different frequencies of red light, as James was talking about, and then as Joshua was talking about all of the stem cells and how important that's going to be throughout your life to try and help reconstruct the body. And then, as you get into serious diseases, what Roger's working on is just just a very nice combination of different tools, and I'm really excited to see how that all comes together in the future and benefits all of us. But thank you very much for inviting me today, and it was really great to participate with all of you.
Well, Chris, that's a beautiful summation. Much appreciated. We've got it recorded. We'll play it back multiple times. So thank you for that. I know it's late there in Lausanne, but we sure appreciate your being with us.
Thank you
Dan,
all.
can I just follow? To you, Chris, thank you so
Sure,
much.
Thomas.
Dan, can I just follow up something that Roger said? I've sort of been fastly making the assumption that for healthy longevity health span products to be even optimally effective, their highest and best use is to supply them, administer them to healthier, younger people. But Roger's comment about DAFA suggests that actually you don't necessarily want to give certain kinds of interventions to younger, healthier people, at least until they crossed over into the senescence side, the post-reproductive age side. So just something that I guess I've learned something here, or I hadn't really thought about that before.
Good point.
That's
Thank you.
And Josh.
I also want to give my thanks and appreciation for the meeting, and I really learned a lot from my colleagues. Look forward to interacting with everybody again in the future and following the progress of the Thrive Act very, very closely.
Josh, many thanks. You brought so much to the discussion, and we're going to be looking for new data coming out soon.
We're going to have our readout of our pivotal trial in HLHS next summer. So
Wow. Very exciting.
under 12 months, and that'll be Longeron's first pivotal BLA potential enabling study. So be on the lookout, and it will be announced.
And you've got others
forward
coming
to
up.
it.
So we're looking for them. Thank you, Josh.
All right.
All
Thank you.
All the best to everybody.
the-
Well,
You know, Zan,
right.
there was a question. I know before we go, there was a question following on what Josh just said about the Thrive Act. One of the first questions in the chat was from Scott Faulkner, who simply wanted to know, and we'd all want to know, whether it has been introduced in Congress yet.
Well, we need to get Scott Faulkner's help. He is a political uh, uh, and quite an accomplished one. He was CEO of the House of Representatives, and so he knows where the bodies are buried, literally, in Washington. And Scott will double back with you about getting your guidance on how to approach the Hill. We have done that to some extent, but we're not experts in that domain. We're just coming up with what we think will be very attractive bipartisan support. This is something everybody wants. They want to be able to do something about preventing multiple chronic diseases, and all solutions that work should be made available as soon as we have the evidence that they do. So that, in a nutshell, is what the Thrive Act is about. And yes, indeed, we'll double back with you, Scott. Thank you for the question.
it begs the question, what level of evidence is going to be required? It's many of us here, and we're all biased in favor of the fact that we spent a lot of time and a lot of money working on evidence, and therefore we like the complexity and the challenge, and in that it keeps other people out, in that the people who haven't paid the money, done the work, and have the evidence. And how's FDA going to set, what bar are they going to set for health and longevity? I mean, I'm sure it's a conversation they've been in before.
Yeah,
It's something they've got to figure out.
That is a key balance to strike. And as Josh was referring to, in Florida, you can hang up your shingle and start injecting so-called stem cells. And it may help, it may not, and it may hurt. So we're not for that. We're not for getting ahead of the data, products that work. On the other hand, we want to see incentives to encourage companies and investors to get into the hunt for evidence-based product development, just as all of you are doing. With that, we believe the balance can be struck, but we see a lot of good, bad, and ugly in this field. And we don't like the bad and the ugly.
Mm-hmm.
There's a question in the audience ask about DHA is being beneficial as a supplement. Can I answer that question?
Yes, go right
Please
ahead,
do.
Roger.
Yeah, this boils down to the fundamental issues why DHA is beneficiary in the food supplement, but it's so bad in cardiolipin. Remember, our body never trusts anything we eat. If we eat a protein, it will be digested into amino acid. If it's not absorbed, the whole protein to be used our body part. So is all the fatty acid we take. DHA is used to supplement. It does probably benefit to the brain because brain has very high content of DHA. That's why aging affects the brain so much. DHA is, enriched with double bond, it's highly sensitive to oxidative stress damage. However, what incorporated into our lipid is not determined by what we eat, is regulated by mitochondrial behavior or function. So the remodeling take place in the ER. The ER is the fuel depot, is like our fuel tank. All the fatty acid is synthesized there, all stored there. The availability and how this enzyme choose DHA, our enzyme choose DHA, is a $1 million question, because we found early on that this enzyme prefer DHA. Remember, during onset of aging, human being, the DHA content in cardiolipin is gradually enriched. As we get older and older, it's almost like the fuel gauge. You have very little fuel left. That's why I showed the graph where DHA content is inversely correlated with longevity. So when we get, let's say, 60-year-old, our mitochondria has, if you analyze the cardiolipin structure, which was pioneered by Xianlin Han in our institute, he was a lipidomics expert. It's very few labs can analyze the cardiolipin structure. Xianlin Han's lab pioneered that. So he actually reported very early on, almost like 15 years ago, if a person developed type 2 diabetes, and later on other people find that heart failure in every cases, it accelerates the incorporation of DHA content, DHA into cardiolipin. So that's main accelerated aging. If you have a diabetes, you have a heart failure, you age faster. I hope that answers all the question. Is what we take is completely different from what our body use, especially this enzyme have a preference at the ER.
Yeah, that's a great point.
Well put.
It's getting the effector to a target receptor signaling pathway. That doesn't happen just because you put it in your mouth.
Yeah.
So very well said. Gosh, well, Thomas, you're still up. You got a big day ahead of you tomorrow. And we also understand that you're going to accept a award for this product that is currently also on the market. You want to say a word about that?
Sure, we're very gratified. This is a dietary supplement that Michael Zemmel invented, I believe. And it is housed in a subsidiary of Kinexum called Newsert. It's a long story, won't go into that now. But Michael, do you want to say something about Lucix, the supplement? We have a pharma side and a supplement side. We have the supplement on the market. We have clinical data. And we're also working. Ooh, am I still connected?
Yes.
Yeah, you are.
I just got a disconnected notice. I don't know what that was. We have a phase 2 program on the pharma side, and we have a supplement on the market now available on our website and on Amazon.com. Michael, do you want to comment on it?
Sure. The pharma side and the Nutra side are distinct, different products, clearly different products. On the Nutra side, the product that Thomas is referring to is one for weight management, and it is built on a combination of catabolic signaling through SIRT1, as well as inhibition of adipocyte lipid synthesis. And it's an interesting combination. It worked well in cells. It worked well in rodents. It worked well in humans. If we took it through 3 clinical trials, the first of which was short-term just to show increased fat oxidation, as well as improvement in inflammatory biomarkers, and then put two additional companion trials, 2 additional trials that were run concurrently, one in individuals under caloric restriction, one in individuals without caloric restriction. And we're able to show very nice weight loss, very nice fat loss with really minimal lean mass loss, improvements in insulin sensitivity and inflammatory biomarkers. We then used the human as a model for the dog. We went ahead, we said, if it works in people, maybe it'll work in companion animals. And actually, we had a vet school do this, and it actually worked out quite well in fat dogs. So it does not have drug-like efficacy or GLP-1-like efficacy. But we think it could be pretty interesting for those people who are rotating off the GLP-1s, as they typically do after a year or slightly over a year, to help preserve what they've worked hard, the weight loss they've worked hard to get to.
And there is a drug product that, as you mentioned, will be in a phase 2 trial in the near future.
Yeah, we actually have completed several phase 2 trials, but we're working on a new indication, and so we'll be starting that phase 2 trial before long.
And
So
is
Michael
it worth
doesn't
saying
have many
it's
comes.
a combination? The leucine supplement is a combination of the essential amino acid leucine and vitamin B6. It was Michael's seminal discovery. Who would have thought that adding leucine would be synergistic with various healthful compounds? I think we have data, some a little clinical, mostly preclinical, with resveratrol, NAD plus donors, beverine, other compounds like that. But on the pharma side, it's a low dose combination of metformin, sildenafil, and leucine. So something that we think would be a great, if it works, would be a great contribution to global, accessible medicine.
Exactly.
Are you synthesizing leucine or something? What's the source of it?
Oh, so we purchased, I mean, there's
Right.
GMP leucine, pharma grade GMP leucine, which the best leucines, which is what we use, is produced by fermentation.
Uh-huh.
And one question that comes up is that there's plenty of leucine in the diet. And so what's the difference between just eating a good, healthy, full of leucine diet and taking this product? And
Wrong with my
the
Greek
answer,
yogurt.
Michael,
It's a great
yeah,
question. I'd like to pretend that wasn't planted, but it probably was. It's a great question, and the answer is this. Your fasting leucine is on the order of 1/10 of a millimolar, 100 nanomolar, give or take. If you have a really protein-rich meal of high-quality protein, that will go up 2.5 or maybe even threefold. It's 250 now, or 0.2, a quarter of a millimolar up to maybe 0.3 of a millimolar. That's not enough to do anything. We've done the PK work. We need to get it up to approximately 0.5 millimolar, which does require the supplement, and it needs to be taken in one fell swoop, not over the course of a long meal, in order to get to sirtuin signaling. And the follow-up question for that sort of thing usually is, ooh, leucine, doesn't that stimulate mTOR signaling? That's something we'd like to avoid. And the answer is yes, but you have to get really high concentrations of leucine. You can do it in a laboratory. In a lab or in mice or rats, it takes somewhere between 1.5 and 2 millimolar to get to increased mTOR signaling or mTORC1 signaling. We don't go anywhere near that range. We've got a nice plateau that occurs well at 0.5, and you have to take a lot more leucine to get to that anabolic range. And while we have not measured in clinic, for example, taking muscle biopsies to show that mTORC is not activated, we have done it in our animal studies, and there's absolutely no effect.
As in many cases, it's finding the Goldilocks zone that makes the medicine or the supplement work.
Yeah, for every medicine, and that includes light as well.
that's
Yeah.
right. Paracelsus said all drugs are poisons. It's the dose that makes the poison a drug.
The medicine.
Yeah, absolutely.
I
Favorite
would have
quote.
I would have said that in Latin, but
I have a
well,
question for the panelists about the fundamental issue of aging. So despite the fact that our average lifespan has increased, our maximum lifespan has not surpassed the previous record set by a French lady, Jean Clément. So
Yeah.
what is the fundamental issue behind this? Is the human genome, whatever built for the maximum usage of longevity is about 120, 22 years, 25 years. Why is that? It's
Well,
fascinating.
you know, there is a dogma that is built in, that it's related to telomeres and other biologic phenomena that just lock or make a ceiling to our survival. But there is a school of thought that we can hack these different targets to get to be able to even live longer, not just have greater health span. And that, in theory, is feasible if we can think it. It eventually can probably be done. I don't know of any
Yeah.
safe and effective approaches that will help us to live beyond 125. But
Then that's why I asked the question, because we often
Yeah.
hear scientists comment with the commercial interest, say a baby lived 200 years already born today. I just don't believe that ever
well,
be
I
true.
yeah, I think that's harmful
Yeah.
for that kind of assertion to be put out. And it's just not based on evidence that we've got something that can do that now. It's not to say that we shouldn't be looking for it and shouldn't use it if we found it. But it's a disservice to tell folks that we're right around the corner from living to be 200 years old.
Well, Zan, I look forward to discussing that in the 2075 edition of THL.
Indeed, I'll see you there. And I guess maybe that's the signal, Michael, to bring down the curtain on this session. It has been a great discussion. I really appreciate Roger and James hanging on this long, and to Thomas for staying up so late. And, thank you out in Palo Alto, Emma Snyder, our great new associate, and to Saif, our Zoom master, for getting us all on the screen. So with that, maybe we'll close the show, and a recording will be coming out shortly to those who would like to look at it or pass it on to their friends.
Thank you.
Thank you.
Thanks.
Thanks,
Thank you,
Em.
Dan.
Thank you so
Bye-bye.
much,
Thanks, Thomas.
everybody.
Thanks, everybody.
Thank you.
Bye.
Bye
Bye-bye.
now.